meeting of the CCG governing body. So just to start off, apologies for absence. We've had from Jerry Wedge, and Dr. Patty's not joined the meeting yet, but I'm hoping she'll join shortly. So any declarations of interest linked to anything on the agenda or new to your role that you want to state? Should give you a second. Okay, perfect. So if I take us straight on to the minutes, just in the interest of time and convenience to me, I shall give you a couple of seconds to nod if you've got questions or comments about anything in the minutes. And I see no comments or hands up, so I will take that as approval of the last set of minutes, and we'll go on to the action log. So the first one is an action owned by Amanda about where we're advertising the future CCG meeting. So I gather there was comms that went out to the papers and to the Health Forum Committee, and it's been Twittered and Facebooked, as it were, and on the appropriate social media. I don't know whether you wanted to add anything else, Amanda, to that. If you're here. I can't hear you, Amanda.
Would you like me to come in, Hassan?
Yes, Simon, are you able to?
So I can pick up that. So we've done much social media advertising over the past week or so, various references to the governing body meeting that's taken place this afternoon. Also, there's been communication that's gone out to the Health Forum for them to share with their members. And we've also promoted it on our websites as well. So a fair bit of proactive media and social media work that's taken place over the past week.
Okay, thank you very much, Simon. I suppose we'll find out, won't we, how many people had access to the meeting or hits to the website. I suppose it'd be good to try and capture some of that data. 1087.0. So Pam, I spoke to you earlier on. So it didn't go to Health and Wellbeing Board, but it's been presented to the appropriate committee. Did you want to add?
Yeah, absolutely. Let me just remind myself of the committee that it's been presented to. And if colleagues are not familiar with this committee, just bear with me a second. It was developed by the Essex Sexual Abuse Strategic Partnership. So I'm sure that's where it was presented. And if colleagues would like me to request that they send it to the Health and Wellbeing Board, that could be done, but we've been through all the minutes and actually it hasn't been presented there. But I think Lisa's put her hand up and I'm sure she'll assure us that that's a multi-partner group and pan-Essex anyway, so I'm sure that's the appropriate place for it to go. But I'll turn to Lisa.
Thanks, Lisa.
Thank you. It is a multi-agency group, Pam, you're right. And I did, so Mid-Essex have been leading on this for Essex. And when I fed back that it had been approved at our governing body, I did also feed back that we would like them to consider taking it to Health and Wellbeing Boards. So they will take the lead on that. Okay, thanks Lisa, and thanks Pam for updating. And the last action was closed. So that takes us on to the main agenda, so let's start with you, Ed.
Or did Max want to come in?
Oh, sorry.
Sorry.
Max, got your hand up.
Yeah, just on that last action point, can I just clarify what the status of the GP wellbeing strategy is? I mean, is it just a sort of what, because obviously there's some proposals in it, and I don't know what the status of it is as a document. Is it like a working document? Is it? Can we say that the proposed? I'm not quite sure, because I was told that it wasn't for the GP commissioning committee to. I mean, it's gone to the GP commissioning committee, I know, but I not necessarily aware that they've agreed it as a strategy. So I'm just wondering what the status of it is. Sorry.
No, thanks, Max. Pam, did you want to answer that?
Yeah, so I think it's an unusual piece of work. I think we haven't gone into this space before, and I think that's why it's a little bit clunky as to exactly where we place it. But we circulated it to board. It's a very important document. It's been worked up with you and with other GP colleagues, with the LMC. I don't actually think there would be a place that we would want to challenge that work. I think any investment that's required alongside that work, we would take through our usual investment panels and use the document as reference as to the context as to why we would consider that investment. But I think it stands as a very organic and appropriate piece of work. I haven't had any feedback from board members that they disagree with the content or feel that they couldn't work to that. So as my understanding is, it's a working document.
Yes, I'll just come back on that. I mean, there was one thing in there which doesn't require any investment. Actually, it's just more a question of whether practices can do it. Is actually this catch-up time, lunchtime catch-up time, there's still a bit of confusion out there about whether practices can or cannot do that. Some practices are doing it, I believe. But it'd be nice to know that that is something that practices can do, you know, because there's a bit of pushback still going on within the CCG about that, you know, saying, well, actually, no, we don't think that's a good idea. I know there's been a bit of controversy about what it's called, and it's not a practice closure. It's basically a time for practices to catch up with their morning work and just deal with only emergencies for an hour.
Yeah, so we've worked with NHS England on that concept and the LMC, and there isn't objection to that. So if there's a level, if you come up against some more objection, Max, I'd like to know about it. I think what we are endorsing is that, you know, practices are like no other provider arrangement, that actually it's impossible if you keep the doors open the whole time to have a practice meeting as a whole team in a way that if you've got departments, they can cover for each other in a large provider. So we recognise the need for that. We recognise the need for catch up, and we've worked with NHS England to make sure that it's implementable without causing contract issues.
Thank you, Pam. And I think, you know, that might dovetail quite nicely with the suicide awareness training that we're trying to roll out. And, you know, maybe that we can say with that hour is a bit of protected time for all the practices to spend a bit of time, and we can maybe talk, you know, because it's still having problems getting that rolled out, that suicide awareness training.
And I think.
Thanks, guys. So I think perhaps what we should do is, if
I'll finish there. Yeah,
it's okay. If there's practices that wish to take that up and they're being met with that's being met with resistance, I think that's the point. Escalate to Pam.
Yeah.
Thanks, Max. Okay, let's move on to the Chief Exec update then. Thanks, Ed.
Thanks, Chair. So firstly, just a congratulations to everyone. So NHS England published their annual assurance ratings for CCGs last week, and North East Essex was given an outstanding rating. So the only CCG in Essex ever to get an outstanding rating, and only one of a handful nationally. So many congratulations to everyone on the board and staff, obviously, and the partners. Secondly, the CQC, the Care Quality Commission, have just done a system review of Suffolk and North East Essex integrated care system. They've done 8 reviews nationally, and they delivered a really glowing report yesterday, which highlighted the collaboration and mutual respect, the learning ethos and the humility that leaders were showing. So that was brilliant as well, and they drew out some excellent examples of how the North East Essex Alliance had worked together during the COVID pandemic to illustrate the point. So again, a great reflection on the teamwork and the culture that we've got locally. Thirdly, I wanted to just talk about COVID vaccination briefly. I know Lisa, who has the unenviable task of sponsoring this for us. There's a huge piece of work that we're doing to get ready to vaccinate our population. Our vaccination programme is obviously in our through NHS trusts, through setting up community testing sites, and there's a lot of interest in where those sites are and how they'll be accessed, and there'll be more information in the future, and through primary care networks. So just wanted to pay tribute to everyone who are working on that programme. Likewise, we've got lateral flow testing kits for COVID testing that are being delivered to our providers to ensure that we have quick testing, point of care testing to support the operations of the service. I wanted to highlight the fact that ESNEFT did more cancer activity in September than any other trust in the country, which is a fantastic achievement and shows how well and how hard everyone's working locally to recover our services and to provide the best service possible. We've got EU exit on the horizon at the end of this month, and Pam's our SRO on that and is ensuring that we've got our business continuity plans in place and that preparations with all of our partners are moving forward. So thank you to Pam and colleagues on that. The government published its comprehensive spending review last week, which announced £3 billion additional funding for the NHS nationally, which will go towards waiting lists and mental health services in particular. And they also announced a levelling up fund for communities that require more support, and we'll keep our eye closely on that fund as more detail is announced, and we hope we can get some of that fund to North East Essex. The final 2 points I wanted to make are important in different ways. So firstly, the ONS have published their national suicide data by local authority, and Tendring and Colchester, I think, were second and third nationally in terms of the suicide rates, which is a huge concern for us in Essex, and the Essex Health and Wellbeing Board have discussed this and have a strategy being developed. But we agreed as a North East Essex Alliance that we would raise the stakes in terms of our commitment to addressing this challenge and give it a really strong local focus. So I'd like to have a discussion on this challenge of suicide at a future CCG board. And then finally, NHS England published a document last week around legislative proposals that will be feeding back on by the 8th of January. But the proposals will have an impact upon the operation of the CCG in the future. Thank you, Chair. That was my update.
Thank you, Ed. Have we got any questions for Ed?
I think Max.
Where is he? I can't. I wonder if I've got a lag here. I don't see.
I'll come in. Yeah, I've got a question. Yeah, thank you very much, Ed. So we've got the suicide rates. It does actually. I mean, we are struggling to get this suicide awareness training disseminated amongst practices, which. I think we maybe just need to think about a bit more as an organisation about how we can make sure that happens, because I think it's really, really good training for practices, and you need the whole practice teams involved in that. I went through it with a practice. I did it with a practice, and it did actually teach me some things, which given that I've been a GP for quite a long time, and I thought kind of think it's something you just know about how to prevent suicide. Actually, I did learn some things, which I am at doing that training.
Did you want to respond, then?
No, I'm not. I think that's really helpful, and it's training like that we need to scale up, roll out, be more proactive about. So I can completely support that.
Thanks, both. I'd pick up on not necessarily specifically the suicide item, but you did talk about bringing it back to board at some point, Ed. Just before the joy that is COVID, we were about to set up bringing teams to the board or bringing a patient story or a particular item. And now that we've sort of settled back into this mode of working. I think it'd be quite nice to try and bring something like that back. So be it a focus on a particular clinical area or a clinical team, just so that there's a bit more focus at board. And Amanda, you were going to help me set that up, weren't you? So perhaps we could talk about that when we next catch up to see if we can try and bring that back.
We've got three other hands, but Lisa, Pam D and Frida.
I think I've got a bit of a problem on my computer, so I can only see Frida at the moment, so I might need a bit of help with hands up, sorry. But Frida, I can see yours.
Can I just come in?
Yep.
Can you hear me now? Because I just switched computers. Can everyone hear me? Ed, I just want to point out something you said, that we don't have lateral flow tests in general practice yet, which is we're still waiting to receive ours. Just to point a note, I haven't received any, and I don't know anybody has. My husband, who's a consultant, has got them at the hospital, but we haven't got them in primary care as yet. I'm sure they're coming, but I just wanted to point that out.
Thank you.
Pam Donnelly.
Just like to come back on Ed's point about suicide rates, particularly in North East Essex, and I think as a wider system, there's quite a lot in the context of knowing our communities and being and I started other role through elected members. So
You keep freezing,
understanding
Pam.
of the issues.
I can't hear a lot of that. I can't. I'm sorry.
Pam, you keep freezing. I'm not sure if it must be your connection.
Okay. Can you hear me now?
Yep.
So I'll keep it short. My plea is that we look at ways of engaging.
Maybe you could try turning your video off, Pam.
That's any better.
I think so.
To widen the remit so that we is in on the discussion and the prevention. Thank you.
Okay. I think so. I think you made a point about widening the remit, about including more organisations in the conversation. Is that what you said?
No doubt is the alliance which we'll need to navigate. Thank you.
Definitely. Yeah.
Lisa, I think you're next.
I just wanted to reflect. I attended a suicide prevention workshop run by Norfolk and Suffolk Foundation Trust the other day, and it's being co-led by the mother, by a mother whose son committed suicide, and it was a really very powerful way of talking about the culture of professionals and society around suicide, listening to her story. So just to support what Pam was saying. And the other really interesting statistic, that for every 1% increase in unemployment, we see 1% increase in suicide rates. So that's in the context at the moment with unemployment raising is a real worry.
Thanks, Lisa. Richard?
Just to add quickly on the suicide prevention comments that Ed and others have made, since the Alliance Committee, we have agreed that the working group will be set up led by Public Health specifically for North East Essex. So it would be timely to bring something back to the next board if we decide that that's an area we want to focus on. And that's going to be multi-stakeholder across Alliance partners, and hopefully taking Lisa's point, service user, those with lived experience in this as well, to build on the work we've already got underway on suicide prevention.
Okay, thank you, Richard. I'm just going to pause for a second. I think I'm having some fun and games with my computer because the hands keep coming and they won't be lowered. So just bear with me. If you put your hand up and I haven't seen it, please just shout and I'll bring you in. Pam Donnelly, you've still got your hand up. Is that new?
No, I haven't. So there's a lag.
Okay. This is going to be fun. Let's see how we go for the rest of the meeting. So perfect. So Health Forum Committee report. Myrna, are you there? You might be on mute, Myrna.
Yes, I've just unmuted myself. You have a copy of my report. I don't know if there's anything that you need any clarification on. If not, I'm just going to present it as read.
Okay, thanks, Myrna. We'll take your report as read. Any questions? Can I ask, was the HFC were presented with the advertising for the board? So I don't know whether you had any comments about that, Myrna, whether you're happy with that or had any other suggestions for Simon or the comms team?
Sorry, I didn't hear all of that.
So you asked a question last board about advertising for the board meeting.
Yes.
And so did you have any comments on Simon's response earlier, or did you want it advertised in any other way, or suggestions from the HFC?
As far as I'm aware, we'll be talking about it tomorrow just to make sure at our meeting. But I haven't heard anything to say that people aren't happy with it.
Okay, thank you.
They're probably saving it up tomorrow.
Well, let Simon know, and then we can work on it, I'm sure. I'd like to get it advertised as best as we can. In which case, we'll move on then. So we'll move on to the items for approval. So I think you're up first, Paul, with the EBRR.
Yes, thank you, Chair. Okay, I'll take this report as read, but it's for noting, but very quickly say a few things, if I may. So September 4th, we were written to by an HSC advising us that we needed to carry out the process of EPR assessment, but we were informed this was going to be very light touch. In other words, review of 1920 associated plans and make sure they were learning from COVID. That was followed by a peer review with NHSE and a table with the paper sort of dictate reflect the outcome of those discussions. The one thing I would point out, though, and apologies, clearly a typo in column 3. It should read 2021, not 1920, and we'll make sure that is changed. There was more notable exception, and that was Practice Plus Group were assessed nationally and not locally. So again, that's one we didn't have a part to play in. Essentially, you will see that as a CCG, as a group of CCGs, we're substantially compliant. I think from memory that we hit 95%, and I think you need 99% essentially to be fully compliant. There were 2 policies that we're still rewriting that we hope to complete by the end of December, which should make us fully compliant by then. So essentially, I pose there, happy to answer any questions, but essentially quite a lot of hard work and quite a really reasonable outcome.
Thank you, Paul. So any questions, comments on us hitting greens? Okay, so we're asked to note the report, or note the update. And so we'll move on to, thanks, Paul. So we'll move on to commissioning intentions. Richard?
Thank you very much, Chair. I'm pleased to be bringing the set of commissioning intentions for Suffolk and North East Essex to the governing body. This is with a couple of key changes from the previous year. So this year is the first time we've developed a set of commissioning intentions across the 3 clinical commissioning groups. And secondly, building on the process last year, it's very much more of a state of the nation almost document, as opposed to a very contractually and financially driven document, which is deliberate, given the significant move in the last year, 18 months towards alliance working and ICS working in its intent. You'll probably be glad to know, Hassan, I'm not going to take you through every section of it. It's a long letter, but we've deliberately done an executive summary. So if colleagues haven't had a chance to look at the full letter, you get a general sense from having a look through the main covering paper. Just to say, you'll see deliberately that in some respect, we haven't even started with the CCG. We've started with a brief overview of the integrated care system, particularly in the context of what we have experienced and continuing to experience with the COVID-19 pandemic and some of the lessons that we're already learning through that, before going into what's the Alliance, so North East Essex in this context, the main deliverables are for the Alliance over the next financial year, and the localities. And it's only then that we touch on briefly the clinical commissioning groups and talk around some of the potential options around the future structural organisation of that, which obviously is quite topical given the report that's now out in the last few days from NHSE and ION on the options for the future of CCGs. I would say if colleagues can read this as a point in time, because clearly given the nature of what it includes, it's a moving feast throughout the year as we react and respond to changing events. So I'll leave it there, Chair, and happy to take any questions that I'm sure my colleagues have who have seen this a few times over the last few weeks. It will go out to all partners formally, hopefully subject to today's sign-off. So all of our providers will receive this, which is the standard that we do each year.
Thank you, Richard. I welcome the combined report. I think it goes some way to us making sure we've got equality across the patch, doesn't it, in terms of service provision, or service received, I should say. Have we got any questions, comments? You might have to help me up. Somebody's got their hand up because I've clearly got a lag.
No one has at this point. I'm looking
Okay.
at Pam. No hands up.
In which case we're asked to note and approve, ready for publication or dissemination, as it were.
Thank you very much, Chair. And just to say, I should have added both Essex and Suffolk Health Watches are supporting us in doing an even shorter, easier read for this, as is ACE Anglia. So we will circulate those for those who'd like to read it again once we get those documents through. Thank you.
I look forward to being able to read it yet again. A great piece of work, I might add. Thank you. So, Jane, you're going to talk money?
Yes, thank you, Chair. So, so presenting today the budget for the remainder of the financial year. As those who've been following this closely will remember, it's been quite the most unusual financial year for the NHS. So almost every meeting we've had a paper on the budget, and it's finally nice to be able to bring one for approval rather than say that one will be coming. But just in terms of context, in the first part of the year, we have been in an emergency financial situation where the NHS has been able to spend what it's needed to do its business as usual, as well as respond to the COVID pandemic and to claim any overspends through a national funding stream to enable the organisations to break even. That regime ended at the end of September, and we've moved into a sort of a hybrid between our usual model, whereby the CCG receives a weighted capitation share of national resources to spend, and the model that's been in place for the first part of the year, which is partly centrally dictated. So whilst we have been given an allocation for that second part of the year, there are bits which are fixed and we can't alter, most notably for North East Essex CCG being the contract with our main providers, our mental health provider at EPUT and our acute provider at ESNEFT. Those contracts are fixed in value, and we don't have any negotiating power to change those. So what the budget does is it basically brings together a piece of work that's been ongoing throughout the year to look at the costs, both for the business as usual work and for delivering the activity under the changing circumstances we find ourselves in, and particularly the excess costs of the COVID response. And you'll see that what the paper does is it sets out the allocation that we've been given as a CCG. That includes effectively what would have been our normal allocation for the second 6 months of the year, topped up by additional funding which is being passed through the CCG to go through to the provider organisations to enable them to continue their work as they have done in the first part of the year. It also includes a small amount of COVID allocation for the CCGs to supplement our normal expenditure where there are specific issues, maybe around our sorry, just getting slightly distracted there by the flashing in by the continuing healthcare, for example, where we've got additional costs associated with the COVID response in the second part of the year. So we do have that extra little bit of COVID allocation. We also are holding, on behalf of the North East Essex Alliance, the share of the system growth allocation. So that's all shown in the table that sets out the various allocation elements. And in the appendix to the report, we've shown how that growth allocation, that little bit of additional money we're given in the second part of the year, is proposed to be allocated across the Alliance. So that's been built up through various different approval committees within the North East Essex Alliance. What it does enable us to do is to put in place and continue some of those services that we had to stand up in the first part of the year, particularly enhanced services around end of life and around discharge services, and gives us enough resource to enable us to continue those through to the 31st of March. So overall, what the rest of the paper does really is shows that in North East Essex CCG, we're in the fortunate position that the resources that we've been given, we assess that they will be sufficient to cover the costs for the remainder of the year. So effectively, we're presenting a balanced budget for approval today. Now, there's just a few little provisos to that. We obviously are now experiencing the second wave of COVID, and there may be additional expenses associated with that have not necessarily been built into the financial plan. But we know that at national level, that is a consideration. We've not experienced significant ones of those yet, but that's just really to ensure that the governing body is aware of those. It also doesn't include, as Ed mentioned earlier, any of the additional funding for the NHS, which has been announced in the spending review, nor does it include anything around the mass vaccination programme, which is being treated separately. So I will pause there, Chair, and see if there are any questions. But effectively, just really asking the governing body to approve this second half of the year budget, which has been looked at in detail by the Finance and Performance Committee.
Okay, thanks, Shane, for making it really clear in that paper, which even I could understand. So have we got questions, comments?
I've got one, Chair, if that's okay.
Yeah, sure.
So I know this is an unknown issue, but the COVID vaccination programme, we're not yet clear, are we, on the costs of that programme? So have we had to build in any contingency to the budget for the second half of the year, or will that be picked up nationally, or have you got any guidance on that?
Yeah, thank you, Ed. It's a really good question. So we are working as part of a system. The Suffolk and North East Essex system is working with the Mid and South Essex system through a lead provider at Essex Partnership University Trust. We've been working very closely with our finance colleagues there to try to pull together the costings around the vaccination programme. But as far as we are aware, and we've received confirmation from Region, all of the costs of those will be separate from this budget. So what we're doing at the moment is trying to quantify. It's a bit of a moving target at the moment as the operational plans are changing, but we are trying to quantify exactly how much that will cost and where the costs will fall to enable us to be able to recoup those and make sure that things operate as smoothly as possible.
Thanks, Jane. Thanks, Ed, for the question. Saved me asking. No one else has their hand up. Can I just double check so in case my computer's lagging? Okay, Martin, did you have a comment?
Yes, thank you, Hassan. Yeah, only to say really that on Friday at Finance and Performance, we scrutinised the plans going forward for the rest of the year, and obviously we were happy to accept that they were robust and represented a sensible way to go forward for the rest of the year. What we've asked for is a copy of the run rate or a presentation of the run rate on a monthly basis and the underlying position every month as we go forward, because we realise, and we've asked as well, that if there are any issues that they're highlighted to us early as possible so we can do something about it. I think a comment that was made particularly by Pam a little while back, and I gave her credit for it on Friday, is that we've done exceedingly well managing our budgets over the last 4 or 5 years and met our controlled totals, and as a result of that we have stayed off the radars, if you like, of the east of England, and that's allowed us some freedom to operate in the way we do. It's also bred success as we've shown we can manage our money. We've been allowed the freedom to manage that as we see fit, and also it's allowed us to become eligible for other sums of money which we've applied for obviously the projects that we've discussed at length today and in the past. So it's very important, I think, that the situation, ensure that we stay within budget and we meet our control total. And I have got a special request actually from the medicines management team. One area where we have got a problem at the moment, we're looking at a £4.4 million overspend on prescribing at the moment. There are all sorts of complex reasons for that, but one of them is inappropriate dispensing and polypharmacy. And the medicine management team, they're arranging all sorts of visits into practices to try and help them out as much as possible. But it's an area where we're not doing particularly well. And you may remember in the past, about 5 years ago, when the trust was in financial recovery, one of the reasons for that was over-prescribing and over-referring as well. But, in the past, we had one practice alone that had put us over £3 million overspent. So it's a serious problem that if we don't get a real grip on, we could end up in a lot of trouble. So I've been particularly asked by the medicine management team to ask, one, if Ed could take an interest in this going forward, a particular interest, and give their team all the support they need, but also the board and the elected members, if they could support the medicine management teams going into the practices, because I think there's a realization that they're very busy, but this is not just about money. It is perhaps more important about quality and safety issues, because not only if we're overprescribing and inappropriate dispensing are we spending too much money on a grand scale, but also we're potentially putting patients at risk. So that's a particular request from the medicine management team and from me as the chairman of that committee to ask for everyone's help.
I don't think there's been a shortage of people volunteering to support Martin in that request. I think it's probably, so as you know, the medicine management committee, the medicines management team representatives meet with the elected members almost weekly at CRG, and so I think if there's a proposal, I'm happy to look at that. Patrick, you've been very patient.
Yeah, thanks, Hassan. I was just thinking, Jane, about, given the comments around COVID and preparation for COVID, just about EU exit and what consideration, if anything, there's been through real risk assessments and budgetary reserves.
Yeah, so I think the main impact is likely to be on the prescribing area due to price increases. That's in terms of CCG budgets, obviously been much more widely across health and care. But in terms of our prescribing budgets, we do use a forecast which is calculated for us, which takes into account expectations about price increases. So hopefully they've been reflected, and as we come onto the finance report, you'll see what our the information that Martin's speaking about in terms of how that's going, or how we're forecasting it for the rest of the year, and how it does fit within the total. But it is quite difficult to predict other than that. So yeah, the regime that we're in for the second half of the year doesn't allow us to hold significant contingencies, although there is there is a little bit of room for manoeuvre in the budget, and we are going to have to keep a very close eye on it.
Okay, thank you.
Thanks, Jane. So any other questions, comments?
I have my hand up. Yeah, I just want to say to Martin, thank you for what you said, and I understand exactly what you're saying, Martin, but I think one has to be very careful with the wording one uses regarding over-prescribing and safety, and there's multiple issues why we're over budget, and it isn't just down to poor practice in general practice. And I do defend my colleagues on this point, and I think you have to be very careful how you word and say things about primary care in terms of safety and over prescribing, etc. I think they're words that we just aren't very fair.
Okay, point well made.
Can I come back on that, please, Hassan?
If you want to clarify, yes, Martin.
Yeah, I do want to clarify that, because I chose my words very carefully, because they're not really my words. They're the words of the Medicine Management Committee. And as I said at the beginning, the reasons overall are complex, but some of the reasons I've given there were their words, not mine. And I can't just ignore them. I have to bring them to the attention of the board.
Okay. Thanks, Martin. I think it's probably something we could take offline to have a conversation around understanding the issues, but I don't think over-prescribing is actually a term that I would recognise, actually. Let's go back to the recommendation. The recommendation was to approve the report. Everyone happy? Thanks. So now we're on to terms of reference. Now, Amanda's been having some technical issues, so I don't know whether are you working, Amanda? Can't hear you, Amanda. What I might do is while you try and figure that out, I'll if I take us through the terms of reference. I mean, essentially the paper is asking for board to approve the terms of reference which should have been to each individual committee and approved at each individual committee. Amanda, perhaps you could use the message box if you wanted to make a specific point while you're figuring it out. So I guess the easiest thing to do is to take it one at a time. So I'll Frida and Martin, you've both still got your hands up on my computer. Can I just check, is that?
Okay. Sorry.
Any problems? It's just I can't seem to lower them for some reason. I've not been given the power. I'll take yours as an old hand, Martin, yeah? Okay. So let's go down. So governing body terms of reference, I've just got one comment to make, and that is just that the terms of reference do mention TDC and OpExec, and so that's because, as you know, we've had a revised constitution with a change in some of the subcommittees of the board. Hasn't formally been agreed by NHS England, which we're waiting for, but I'd like us to agree the terms of reference under the understanding that once we get approval, seeing as those committees are functioning anyway, we'll just change the committees to reflect the actual subcommittees within the board. So I'll just pause for a second, see if anyone's got questions, comments about governing body TORs. Okay, please shout if I ignore your hand, because I clearly can't see them. Then we've got audit committee. Thank you, Mark. Remuneration and HR committee. One comment from me just to add that we agreed that it would make sense for us to have two permanent members of this committee as lay members, and so Jerry and Martin were volunteered and agreed. Okay, finance and performance committee. GPCC. The operational executive. And the joint CCG collaborative group. Now, nobody's got their hands up except for Martin, who's got them up on my screen still. So I'm assuming that's still the old one. Unless anyone's got any comments or shouts now, I'll take it that we're all happy with those terms of reference and we'll approve them. Okay.
Hassan.
Oh, sorry. Pam?
Sorry, can I just say that the board has seen the terms of reference of the Alliance Committee previous to today, and they should be read in context alongside the Operational Executive Committee terms of reference, so we can issue those for ease if people want to do a comparison.
Okay. So as you say, we've agreed them already, Pam, but you can recirculate them afterwards. I think these have come up because they're due for reapproval at board, which is why these have been selected.
It's just for context, reading them alongside.
Okay. I'm sorry if I missed your hand, but I'm taking silence as everyone's being happy. So we'll have to work with that. And so we'll move on. Thanks, Amanda, for your comments. I hope you figure out the IT issues. It'd be useful to get your involvement, sorry. So then we're up. I'm not, by the way, taking you through the whistleblowing policy. Someone else is going to have to do that. Jane, you own the counter fraud policy.
Yes, thank you. So in our series of bringing together and updating policies, we've got to the next. Shall I just take the next three while Amanda's, if
you can,
if that works. So the audit committee has looked at the three policies that are coming today. The first one being the counter fraud, anti-bribery, anti-corruption policy. We've worked with our internal audit counter fraud providers to try to make sure that this picks up the best of the existing policies that were in place across Suffolk and North East Essex, and hopefully what we've ended up with is a kind of comprehensive policy which will be really nice and clear for people in the event that they do find any instances of fraud or bribery and corruption. So it has been reviewed in detail by the audit committee, so hopefully the board is happy to approve it.
So you might have to help me out, see if somebody's got their hands up. I don't think anyone has, on my, apart from Martin, who's still got them up on my screen. But
In which case, shall I just carry on through, and
yes,
I'll look out for hands as we go through.
Thanks.
So we're just trying to flick quickly enough through. The next one we come to is the
whistleblowing.
Yeah, so the whistleblowing policy, in a similar way, again, what we've done on this one, we actually we did use some of the things from the existing policies across, but we actually looked to the NHS EI, who'd done a best practice policy on whistleblowing, so we used that as a basis, and again incorporated kind of local parts to that. So hopefully, again, this is an up-to-date policy which will be useful and will help any staff wherever, regardless of where they work in the joint management team, if they do have any whistleblowing issues. And the final one.
I've just got sorry, Jane. I've just got a message from Amanda to say, can I see if her computer's working? So are you with us, Amanda? No, it's still not. Carry on, Jane. Sorry.
Okay, thank you. And the final one is the risk management strategy, which again has been looked at by the audit committee. We've developed this with input from the internal auditors, particularly picking up on recommendations about the way that risks are reported at the moment. And hopefully this new strategy will help to bring some alignment across the 3 CCGs, but also provide a kind of clearer reporting framework going forward. And just to say, with all of these 3 policies, what the audit committee realises that if we just want to do a kind of names and numbers kind of update, that what we're asking the governing body to do is, if we're just changing role titles, etc., asking that we can devolve that to the audit committee to save them having to come back to the governing body, apart from when there are major changes to be made.
Thank you, Jane. So the ask is us to adopt these policies.
It is.
So questions, comments? Okay, perfect. In which case we'll agree to adopt all 3.
Thank you.
Thank you, Jane, for stepping in, and thanks, Amanda, for trying. So now we move on to questions from the public, and I'm aware of 3 questions, and Simon's going to just steer us through those. Simon, if you're about.
Sure. So the first question from Mr. Ratford is, what provisions are you making to ensure that kidney transplant individuals and other similarly vulnerable people receive a COVID-19 vaccination at an early stage? That's the first question.
Okay, so I'll wait to see if somebody wants to jump in. But at the moment, I suppose there's still some clarity around the regimes or around the specific group of individuals that will be selected for the vaccination. So as we understand it, once a vaccine becomes safe and able to be used, the initial group will be care home residents, if not met with or matched with or followed closely by NHS and care workers. And following that, there's a tiered system which goes from, I believe, 85 and above, 75 and above, and there's an approach. But that's the proposal at the moment. But I wouldn't like to say for sure until actually the official guidance is released. The essentials, I guess the summary is that it's age-based rather than health risk-based. And so that's the approach that NHS England will have advised us that they'll be taking. I don't know whether anyone else wants to correct me on that or...
Lisa's got her hand up.
Okay.
Hassan.
Okay.
I was just going to agree with you, Hassan. So you're right. The care home residents, health and care staff, and over 80s, over 70s, over 60s, and the clinically at risk vulnerable patients, of which the patients that this gentleman's referring to may be one of them. So it's very much being done from a risk group, so all that will be taken into consideration, but you're right around the priorities that you stated.
Thanks, Lisa. So I hope that answers the question. Simon?
Thank you. So the second question is from a Mr. Stevenson, and he writes the following: given the rollouts being planned for the COVID vaccination programme, are there any plans for serving the more outlying districts through local amenities, for example, village halls? The reason for this is that I am, with many others, in the over 75 vulnerable group served by Tiptree Medical Centre.
So I might ask for your input on that, Pam, but my understanding is that nobody will be denied the vaccine, and so we will be looking at a model that allows for delivery of vaccine to everyone within our patch. our patch being northeast Essex. So Tiptree, seeing as I don't live too far from Tiptree, won't be excluded from that patch and should be definitely part of that rollout scheme. Pam, did you want to add?
Yeah, so and Lisa, I'm sure will come in as well. So there's two streams to the rollout. There's mass vaccination on a big scale where people can drive to and are able to do that, and we can run a very efficient model in big premises to cover people. But also there's recognition that that's not going to serve everybody, and that's not going to also be accessible to everybody. So the model of working with GP practices, also working on a roving model, so that can we deliver the vaccine into those remote areas, are options that are all being considered at the moment. Remembering that the early stages of the delivery of the vaccine are the conditions are very, very specific. So as the vaccine evolves and it becomes more stable, we'll be able to be much more innovative in the way that we deliver. But primary care is a very big part of the delivery model. And there's good things coming around the Oxford vaccine. All of these vaccines are yet to be licensed and approved, so we wait for all of that information to come through, but as the more stable versions come online, we will absolutely use a model that's less based on big centres.
Lisa?
And just to add to that, so part of the work that we've been doing is ensuring that the vaccination sites that we agree are across Suffolk and North East Essex in the places which ensures equity of access for people, because we absolutely want to make sure that everybody can access a vaccination site within a reasonable distance. So that's the first point. I'm not sure if Tiptree Village Hall is one. There's been a really clear specification for the places that we're allowed to use because of all the storage and all the infection control guidance and everything like that. So it's been through a really rigorous estates approval process. And just the other thing I wanted to add is that we have done equality impact assessments on every piece of work that we've done, because something that we really want to make sure that we get right in this vaccination programme is equity of access, and making sure that we don't disadvantage anybody because of where they live or their ability to access vaccinations. So that's been a really important thread that's worked through, that's kind of been present through all the work we're doing on the vaccination programme.
Thanks, Lisa. Simon, you got more?
Okay. And the third and final question relates to the whistleblowing policy from Mr. Larkin. The question is, are the directors absolutely confident that a low status employee can raise such an issue and that the issue will be dealt with fairly, and that the said person will not suffer in any way by raising a concern? My concern is that an individual needs to follow a process, and that makes them very vulnerable. Are the directors absolutely confident that there is sufficient protection in the policy for particularly low status whistleblowers?
So I'm guessing Amanda still can't respond at the moment, but okay. But she's messaged that she is confident. I don't know whether you wanted to have just reinforce that, Ed.
Yeah, no, absolutely. We're very, very confident in the policy, and it's something we've talked about with our staff as well in recent committees. So yeah, absolutely committed to that.
Thanks. It's also worth mentioning we've got I was just trying desperately to look who it was before I say famous last words. We've got a whistleblowing champion, amongst lay members, and I believe it's Jerry, if I'm not mistaken. So we do have a lay member who's a champion if there were ever any concerns around that not being the case. Lisa, you got your finger up. You're talking at me.
Talking at you, but left my mute button on. Sorry. So, I've been working closely with Amanda, and Amanda's done a great job with this whistleblowing policy. And I'm not sure what low status employee means, because I don't think we would consider any of our workforce to be low status, but I as a director, I would be entirely confident that anybody that wants to use our whistleblowing policy would have an equal standing with that and have their anonymity protected.
Thank you, Lisa. So I think that's a resounding yes. We would. Is that your lot, Simon?
That's those are all the questions. Yes.
Perfect.
Thank you.
Well, thanks so much for taking us through that. So let's move on to operational reports then. So Lisa, you're up first with safeguarding.
Thank you. So this is the annual report for both children and adult safeguarding, and it presents the how we coordinate our safeguarding responsibilities and assurance processes across North East Essex CCG. So it details the training compliance. The point raised in the report in relation to Suffolk executives, I can confirm that the Suffolk executives are in line with their training, but we are now looking at some joint training for those of us that sit across both Suffolk and North East Essex by both teams. So we will be planning that joint training. The report also reports on the set-wide child death review process, which you'll know is provided by the Princess Alexandra Hospital in Harlow. Across sets in that year, there were 10 deaths, 6 expected and 4 unexpected. Obviously, the unexpected deaths also go through the SUDIC process. And one of those was female and 9 male, and the majority under 1 year. And the Safeguarding Children's Board has recently relaunched its safe sleeping campaign, as a number of them were related to not having safe sleeping processes in place. During 1920, there were no domestic homicide reviews and there were no child safeguarding practice reviews, the new term for serious case reviews, commissioned during 1920. That will be different in the 2021 report, as we have commissioned some CSPRs. We have completed the Safeguarding Commissioning Assurance tool, which is a tool that we do for regional assurance, and we did answer no for 2 questions. One, we do not employ a designated doctor for adults. It's not a role that's in the intercollegiate guidance. It's not a role that's employed by any CCGs. So we're not an outlier in that, but we're just trying to understand from the region what the expectation is around designated doctor for adults as opposed to named doctor for adults. And there's a couple of policy changes we need to make to reference safeguarding. I think the other thing I just want to point out is the great work that North East Essex Looked After Children team and our system partners, of course, with Essex County Council and ESNEFT around the initial reviews for Looked After Children. So we are at around 75% now for making sure those initial health reviews are done within a timely time frame. So and of course that does require system working, and George Edwards, the Looked After Children nurse, is very on top of that all the time, working with the ESNEFT paediatric team to make sure that happens. One of the issues raised in the report that is an issue that we are escalating with our Essex County Council and our Safeguarding Children's Board is the number of out of area children that we have placed in North East Essex. Due to the number of independent providers and opening of residential units within that area, which does cause the system and the child involved some difficulties if those placements don't work out, and the child sometimes ends up in Colchester General Hospital, Colchester Hospital. So that is something that's concerning us. It's something that's becoming more and more frequent, where children are placed out of area in North East Essex, and then the placement ends quickly. So I'll leave it at that, Hassan, but happy to take any questions. Thank you.
Thanks, Lisa. So have we got any questions? Martin, I'm really sorry, but for some reason your hand's permanently up on my computer, so you're going to have to wave at me if you've got a question.
It's not up in real life, Hassan.
Yes. Okay, well, if there's no questions, then I guess we're asked to note the report. Thank you, Lisa. Pam, you're up next. Alliance Committee Review Overview Report.
Yeah, thank you very much, Chairman. So I'll take the paper as read, but I would just like to emphasise the breadth and depth of the work being done by the Alliance Committee in context of what Ed started the meeting with around changes to the commissioning landscape and the maturity we're now achieving within that Alliance Committee. So if you look at the scope of the committee content within the paper, I think you'll agree it's pretty broad. We're covering from Brexit updates to decisions around mental health provision, etc., etc. So there is quite a considerable amount of work going through that committee now, and colleagues in our voluntary sector are able to contribute, as our GP colleagues, county council, etc., because of the broad membership there. One notable piece of work that's gone through the committee, well, a couple of pieces, are around the asset mapping approach, which I think, again, as you see in the guidance around changes on place-based approach for the future, actually having your assets mapped within your community, within a locality that we intend to support as a locality, is absolutely essential to ensure that we keep people as well and healthy as possible, and that we invest carefully and as stewards of those assets for the future and don't damage any. So mapping them is really, really important, and enabling people to access them through the social prescribing approach. Actually, if you don't know about them, then our social prescribers can't direct people to those resources that are available at street level. And I think that is very much the sustainability approach for the future. Also, the BAME work is being, so Black and ethnic minority group work, health and inequalities work is being driven through this committee. So we've had significant contribution from GP colleagues, community leaders, and several proposals have been put through that committee. They're being refined at the moment, but that committee will be the one that approves and coordinates that piece of work for the future on behalf of the whole system. So I just hope you don't mind me drawing the board's attention to those pivotal pieces of work going through that committee, and happy to take any questions.
Thanks, Pam. I don't know whether you wanted to add anything, Mark.
Yes, thank you, Hassan. I had put my hand up, but I don't know if that was here for you. So thank you, and thank you to Pam. Really, she's summed up the highlights very well, and also summed up the fact that it's a very wide coverage of work that we're doing. And thank you to the contributions from all those different partners, our local authority partners, our partners in terms of Community 360 as a voluntary service, always doing a fantastic job, the hospice and many others. So it really is working well, and I do think we cover a range of short, medium and longer term issues. So short term at the moment is obviously COVID response, longer term, sort of medium term stuff with some of our mental health highlights that Pam has talked about us investing in, and the longer term work, as Pam has highlighted, on the asset mapping and understanding how we develop our communities to have better health and well-being through sort of co-production of different projects, looking at what we can do together rather than just health in a silo, and local authorities on their own, and people themselves. So some really good work. Thank you for Pam's summary. Nothing more from me.
Thank you, Mark. Look forward to you presenting the report next time. I'm afraid I can't see anybody's hand up, but I didn't see Mark. So if anybody has their hand up, could you shout?
No hands, Hassan,
Okay,
no hands.
right, perfect. In which case, we'll note the report and we'll move on to the performance report. Paul?
Thank you, Chair. Given that this report has been fully discussed at the Finance and Performance Committee, I will go through I'll take the report as read, but go through a few of the key points. And Martin, my apologies for not attending the last meeting, but I was fully briefed by deputy, and you may want to come in having chaired the meeting and have some observation about the outcome of that discussion. And can I then suggest that my colleagues may want to come in and pick up any quality transformation or financial issues, which is also part of the report. So I would describe the report as demonstrating, fairly stable performance with some green shoots of improvement. But I think it'd be prudent of me to raise a number of risks. Clearly, this is September data. Clearly, we're now certainly well into wave 2. We've got winter pressures. We are trying to maintain phase 3 activity. And we also need to very close eye on our workforce who are working tirelessly to juggle all of those priorities as we move forward. And essentially, the performance report is really a balance of all those things and an effect of all those things. So just really to put a clear point here that actually the system is working incredibly hard to maintain the level of performance that it already is. You'll probably note that in the report, for the first time, we actually put in the achievement around the standard around phase 3. And you'll notice that SNF in particular, which is in the table, broadly in October achieved all the targets, with the exception of outpatient follow-ups and MRI scanning. Now, from an outpatient point of view, I'm sure you remember Richard previously saying we're not too worried about this because we're actually doing some transformational work that suggests we may not want to see the same level of follow-ups as we move forward through different ways of working. In the MRI, it's really interesting. Having done a bit of deep dive, it would appear that our referral is not quite as high. And actually, this is evidenced by the fact that our waiting time, the MRI at SNF, in particular, are reducing quite significantly. So which essentially seeing they are maintaining their level of productivity on that point. The other point I would caveat with that is only today I've seen some further update of some of the data, and SNF will carry on improving and practically surpassing most of those targets, again, with the exception of MRI, which is about 85%, I think, from memory. So the system is working incredibly hard to maintain that capacity, which enables more treatments a patient, which indicates more improvement in performance. The other sort of key points I would raise is that we are continuing to work with the private sector and working well with the private sector. We are awaiting the outcome of the procurement process for supporting elective activity, which is due to complete in December. That may give us further opportunities in terms of additional capacity, and we are currently working with our provider trust to see what opportunities we might have to try and be ready for that. So clearly a picture of capacity and demand, which is really quite important at the backdrop and the context of the performance. When you sort of start then to look at things like RTT and look particularly in terms of CCG performance, you will notice that actually there are some marginal improvements in 18 weeks, I think by the tune of about 6-7%. 50 weeks, 2 weeks is marginally improving. Diagnostic is, I think, is improving by 19 to 12 point something percent. Again, there are some evidence that actually the capacity that's been put into place is actually having some effect. The slight context I would put to that is we are still saying lengthening waiting lists, and what we are seeing is an absolute clear prioritization of the most urgent patients and make sure they are managed as appropriately as possible. I think just to echo Ed's point around cancer. My sense of the cancer data that I'm seeing is that we are seeing improvements. And as Ed already stated, I think SNF treated, there's a large number of cancer patients, 60-day patients, I think in comparison to other England trusts. So again, which is usually positive. And they are themselves saying that their backlog is significantly reduced. So again, a tremendous amount of work on their part. So again, you will note that the 2 weeks performance dropped. That was largely due to do with breast 2 weeks waits. The discussion we've had with the trust was that it was a capacity issue, and they've now resolved that issue by putting some waiting lists and resolving the locum issue. So I would expect some of that to improve. So again, we've got a fairly clear understanding some of the things that are driving some of this on the performance. 31 days, there or thereabouts in terms of stability, and 62 days again as reduced in terms of performance. But that standard would be variable depending on how many patients they treat in terms of the backlog, and that's a really important point. So it will count being variable. Just for the interest of the board, I did a very quick look back this morning in terms of performance, and if you actually compare performance September 19 and September 20, it's quite interesting reading. 2 weeks in September 19 was 80.9%, and we're actually at 83.4%. So again, performance is better now than it was back in December 19. 31 days is more or less the same, and 62 days is actually 76.4% compared to 71%. So actually, I think that quite demonstrates a lot of significant hard work on the cancer agenda, which is also backed up by a lot of transformational work that is going on in the background. So I think it is, as much as we are not where I think we should be, because we would want to be absolutely there in terms of standards, I think there are clear evidence that other performance is actually going in the right direction. The only two areas I would sort of pull out is EPUT. I think EPUT are providing quite a strong performance with the exception of 28 days. We have been given assurances that they are prioritizing the patient, working with them to understand what is driving that underperformance to try and resolve some of that. And the other areas that I would pull out would be the 111 service, where we are actually about to go live with some additional capacity to support the winter pressures. So I think I'm going to stop there and allow Martin maybe to come in and maybe give some further overview into the discussion you had at the Finance Performance Committee, if that's all right, Martin.
Thanks,
okay,
Paul.
Thanks, Paul. I think you've left me very little more to say, to be perfectly honest, because I think the overarching impression I got from Friday when we went through every aspect of the performance right across the board, as you see in the paper, is that the bottom line is that we've got capacity issues due to, in the backdrop of the coronavirus pandemic. And it seems to me that right across the board, you know, from primary healthcare into ESNEF to all the other acute sectors, everybody is working incredibly hard, and slowly but surely we're seeing all of the statistics and all of the recovery in just about every area slowly but surely increasing, which is great news. But I think until we get on top of COVID, I can see the capacity issues are going to continue, access to diagnostics being absolutely critical. But I mean, everyone's working across public and private sectors to make sure things are going well. And I think all my sort of overarching impression is that everyone's doing everything they can, and certainly within the resources we're available and within the constraints, I don't think we can possibly ask for much more at the moment.
Okay, thanks, Martin. Was that you waving your hand, Mark, at me?
Yeah,
Here's a hand for Mark.
I put my digital hand up and the physical.
Okay.
Thank you. Thank you, Paul. Thank you, Martin. I think, Paul, really it does show the amazing effort of you and your team, but all of the staff members across all of our different services, acute and into the community as well. I think it's excellent to see, despite all the challenges. I remember Richard Watson saying we would be getting back towards higher rates and better performance, and we are, and I'm really impressed by that. And you're working with the private sector to give us more capacity. That's against my natural ethos, but I think that's the way you have to find the capacity where possible at this point in time. So thank you for doing that. The only one thing for me would be, as you explain the EPUT, the concerns there about the 28 days, and I have read that as you guide us to say that they are reassuring us that they are triaging patients and looking at the extent to which they are at risk. But I think we all know that people are going in for outpatient appointments, getting things that we've known before. But many of us are more affected by the mental health situation due to COVID that we weren't so aware of. We didn't know 9 months ago that someone needed to go in for an operation. So sorry, we did know that. Those things are known. It's the unknowns with the mental health. So I do think that anything we can do there, any further challenge we can put input there, but any further support we can give to ensure that EPUT can support our residents, because everyone is facing a sort of mental health challenge at this point, and those in the most acute situation need that help. And we have discussed previously about the suicide rates. We clearly have a challenge there. We need to support people. Things are going to get worse before they get better in the economic market. So I'm happy to take that offline and give further support, or ask how we as a board can help you further. Thank you.
Thank you, Mark. If I may just come back quickly, and apologies. I would just point out that we have had an incredible amount of buy-in from our partners, and actually they've risen to the challenge significantly. And of course, we will support wherever we can. Okay.
Thank you all. Just checking no one else has.
Yes, Max Hickman.
Okay, sorry, Max.
Thank you. So, Paul, just how are we guarding against that sort of bounce back in terms of referrals? I think a lot of that sort of steady performance that you've described over the last year has been due to lack of or reduced demand, if you like, because of, in some respects, in terms of non-COVID activity.
So I think from memory, depending on what you talk about, if you talk about cancer performance, then from an SNF point of view, their referrals is higher now than it was previously. Now, I can't explain that except the referrals are higher, and they're managing to maintain some of that. In terms of the sort of other elective type, I believe they're slightly down, but I would have to go and double check some of that. What I would say to you is there's a direct correlation between capacity available, new ways of working in terms of the way patients are managed, non-face-to-face and what have you, which the trusts are working incredibly hard to try and manage. And I think until the capacity is there, then actually they will carry on having to manage patients from a clinical priority order. It so happens that for SNF facing, they are doing exceedingly well with their capacity into what they've been able to put back on very, very quickly, and are able to move much more quickly than maybe some of the trusts at the moment.
Thank you, Paul. Has anybody else got their hand up? Sorry, I can't see.
Sorry, Myrna.
I think Myrna.
Okay, Myrna.
Just wanted to put something, because I've had two friends that have been previous cancer patients, and they've had symptoms that have been worrying them. They've contacted me and we've been chatting, and both of them have said they've done nothing about it, didn't think it was the right thing to do at this time, to go to the doctors and to be sent to the hospital. Luckily, I managed to convince both of them that they needed to do that, and they've both been seen very quickly, and I'm quite impressed how quickly they've been seen. And one of them in particular does need some treatment quite quickly as well. So I don't know how we get that message out to the wider public. The NHS is open, and if you have symptoms, especially cancer, and you've had it before, you need to do something about it.
Thank you, Myrna. If I can just briefly come back to that, I think a really important point. The NHS is open for business, and if you have any worries, you need to go and see your doctor or be seen as quickly as possible. From a communication point of view, Simon will want to come in, but we have a significant comms sort of program that actually reminds people the need to go to doctors and see the relevant specialists should they need to. I think it's fair to say that there is a small group of patients, I think, that are still concerned about the COVID issue, and I know the trusts are actively trying to engage with this group of patients to make sure they get the most appropriate care as possible. So a really important point.
Thank you, Paul. Did you want to come back on that, Simon?
I would actually, yes, please, Hassan. Thank you. So I'd like to just say that we've had tremendous support from our local GP and clinical colleagues in fronting many media stories about this, and we've done quite a bit of work in terms of emphasising the points you've just raised there, Myrna, in terms of highlighting the fact that the NHS is open from acute colleagues and primary care colleagues. So lots already gone out in the media, social media, but obviously we'll do more as well as we go into the winter months.
Thank you, Simon. Martin, you were waving your hand at me.
Yes, I was just going to say, and it goes back to what Mark said about the private sector and how they've helped enormously. The Oaks has carried on an awful lot of cancer work in particular, which has allowed many of the performance recovery that we've seen and Paul has reported on has been because we've been able to use the Oaks to such great effect. And I've written to the Oaks on behalf of the committee, thanking them for all of their help in assisting us in our efforts, particularly around cancer and other activity which they've helped in, and that's gone from the committee and me as the chairman of the committee to the Oaks to thank them for that.
Thank you, Martin. Has anybody else got their hand up?
I think I saw Richard's hand for a second, but I'm not sure.
Well, it depends if Chair, you want to talk about any of the transformation elements from Pam and I, but equally I'm happy to take questions if there's anything in relation to the detail within the paper.
Okay. Well, you can talk about transformation, but I've got a question for any one of you, if that's all right. So it's a point I always make when we're looking at percentages, because it doesn't necessarily give you an idea of numbers. And so when you're looking at a percentage, that doesn't tell me whether the numbers have dropped, and so actually the percentage is higher or lower, but that's because there were fewer people going or there's more people. So do we know if the actual raw figures in terms of numbers attending have recovered? Because that to some extent will address Myrna's question, won't it? If we've not seen a drop in numbers, then we should be confident that people are still going. So is that the case?
My understanding is referrals are at similar levels to previous year. Pam's nodding as well.
Yeah.
Okay.
And I think that the trust has done more cancer work per month than it has ever before. So numbers are up and the throughput is up as well. So that's positive.
Absolutely, and not for absolute cast iron, but I think from memory, the number of backlog for 62 days and above is, for SNF in particular, is down to about 200 patients when it was much higher than that. And they have a real ambition this side of this year to try and clear all of the backlog. So we do see the data behind that.
Okay, all right. Well, I'm afraid I can't see anybody's hands up anyway, so I don't know if they are. But so if you want to pick up transformation or give your comments on how we're going to recover this, Richard.
Thanks, Hassan. So Pam and I just quickly cover some of the headlines in the pack from about slide 259. Just on elective, Paul's already given the headline message that SNF is doing comparatively well. Last week's stats actually had them over 100% now for day case elective and outpatient firsts in terms of the amount of activity they were doing compared to the same month of the previous year, and just slightly behind on follow-ups. Most of our focus at the elective care board at the moment is around how we transform differently our outpatient activity. So there's 4 different initiatives that we're working on with the trust. The first is advice and guidance, so that's building on Consultant Connect work that's happening with primary care. The second is Telederm that's being rolled out. The third is around moving to virtual consultations where appropriate, and the trust is seeing between 25 and 30% of their consultations now virtually using the telephone or video consult. And the fourth one is their patient portal. So starting to look at the ability for that portal to do even more over the next year in terms of interactions for service users and staff. In terms of our cancer programme, Ed's already stolen my thunder in terms of the headline figure. Around it's 244 or thereabouts patients were seen and treated last month, which is higher than any other trust in England, which is remarkable given the scale of some of the other major acutes across the country. We're still slightly below where we need to be on performance, but it just gives you a sense of the scale of what the trust is currently trying to achieve. We've also, I'm pleased to say, appointed to the key roles for the Rapid Diagnosis Service. So that's the pilot that we've started across SNE, looking at those with medically unexplained symptoms, about coming in, having them checked in a community setting. Dr. Alice Parr, who is our cancer lead for North East Essex, has been appointed as one of the key leads to take on that work, which is great news for North East Essex and SNE more broadly. Just in terms of the children's programme, I've got the pleasure now of chairing the Essex-wide joint commissioning group for SEND, under Lisa's overall leadership as the co-SRO for that SEND inspection work that we've got underway. We've really started to galvanise ourselves now at last, I think, in terms of taking forward 4 pieces of work. The first is speech and language therapy, so developing a new revised model across Essex for that work. And we've got to provide a workshop in December in a couple of weeks across Essex to look at what that should be. Second is around neurodevelopmental, which North East Essex is leading for Essex. So that's around ADHD, autism, etc. And we'll be bringing a business case through to the Alliance Committee in February, looking at a whole-scale improvement for that area. The third is around equipment, so equipment for children in health and social care. And the fourth is around some of our support package more broadly to local parents, carers and their families through the voluntary care sector. So that work is now moving at some pace, which is great news. And then just finally on mental health, particularly given Mark's comments and others, there's a huge amount happening within the mental health space, which is really, really pleasing. We've still got the mental health board meeting every 2 months. Which myself, and it was Anne Brogan who's now left, so a colleague from EPUT will be chairing. Just some things to give you headlines on. We've now got a business case agreed for personality disorder, which is a huge, I think, part of the jigsaw we've got in our community model. We've also agreed further work around supporting the primary care networks, in principle, I should say, across North East Essex, with EPUT around some additional mental health practitioner roles, building on the ones we've already got, which will provide additional capacity in primary care. And we've also are in the process of developing further capacity with our IAPT and wellbeing service, which again, particularly in the context of COVID, unemployment rate potentially increasing, we desperately need more capacity, more support for that service. So we'll be looking to try and take it up to 30% access rates from 25% currently over the next year or so. So I would say overall for mental health, we're dealing with a lot on the day-to-day basis, but we haven't slowed down the transformation programme. If anything, it's increased in pace over the last 3 to 4 months. So they're just some headlines from some of the latest things that are happening in my part of the world. But Pam, I know, has got some headlines as well to provide.
Is there more headlines, Pam?
Very, very quickly. So I think it's just to close off the fact the flow piece in the hospital. So the Alliance is working very cohesively around how we discharge patients, making sure that the discharge hub is working with care homes. We've obviously seen significant challenges in our care homes recently, receiving patients, and Patrick's online at the moment, and we're working with him around designated settings, using the community beds to support the COVID patients for future, currently, sorry, and that is something that is essential to enable the elective care and cancer work to continue. So we see our role very much at operational level to keep that flow going. We're also very involved in the redesign of the social care package through the Connect programme that's Pan and Essex around reablement as well. So it really is collaborative with Essex County Council on most cases around how we support the system. But I won't go into any further detail now because I know we're short of time, but just to connect the dots on that front end of the hospital piece is very much at Alliance level.
Okay. Thank you, Pam. Thank you, Richard. And thank you, Paul, for that detailed update. Oh, Martin, you're wagging your finger at me.
I did have my hand up, but I don't think you've seen it.
Sorry.
What I was going to ask was, at F&P, quite often where we've got shortfalls in performance, we start to do a deep dive and we look at what's going on. And it seems to me that quite often the fragility in the system is usually due to people at the coalface. It comes down to clinicians, the number of clinicians, and there are all sorts of issues. We can look at how that operating theatres are managed, etc., etc. But at the end of the day, it's how many consultants we've got, how many nurses there are, how many clinicians of different specialisations across that make a real difference. We keep getting told that we're training a lot more doctors and a lot more nurses. Are they starting to come through now?
Richard, do you want to hazard a response?
I don't know if Amanda's mic's working yet. No. Overall, we're looking to increase our workforce by 7%, I think is the headline figure, and we're well on the way to achieving that across SNE. I think comparably across region, we're top of class in terms of being able to both attract individuals to come and work within Suffolk and North East Essex, retain them, and also our sickness rates have been comparatively low. So there is still a challenge, Martin, absolutely. But I think comparably we're doing quite well. And I think that's demonstrated in some of the figures that Paul, Pam, Lisa and others have been through now. But there's always room for improvement.
It seems to me that quite often breast cancer would be a typical example where we had one consultant go down, all of a sudden we saw all the waiting times, all the stats go through the floor just because one person went off sick. And it seems to me like if people go on holiday, all of a sudden we see the service really sort of go back. There seems to be no redundancy in the situation, which has a real impact on at the coalface.
I think you're right, there's particular niche specialisms where one or two consultants go out, and we've got that at the moment with COVID, where in one specialty 3 consultants all went down or had to isolate. It's fragile in terms then of some of the ability to see patients. But as I said, again, comparably, and it's only comparably, the headline figure is we're doing relatively well.
Yeah, thanks, Richard.
Thank you both. So I've got some hands up, actually. I don't know if they're old or new. Ed, you got your hand up? Yeah,
just on that, so 7% increase against a 2% increase nationally, so done very well, particularly at SNF.
That's for staff, is it?
For staff, yeah.
Okay.
Workforce increase. So my point was just to congratulate Richard and Lisa on the work leading SEND in Essex. We're making some excellent progress now, and I just had a message from officers in the County Council saying how pleased they are with all the work that's being done. So it's quite a formidable task given the complexity of Essex, but we're really making some progress now, which is great.
Thank you, Ed. I've got a few people's hands up, but I think they might be old because of my computer. Has anybody? No others?
No hands.
Down.
Okay, perfect.
No hands.
Okay, in which case I'll move us on from this report. Thank you, actually, for the detailed debate. Thank you all. And so we're asked to assure ourselves about F&P scrutiny, so thank you. Lisa, you want to talk to us about quality report?
Certainly. So these are the minutes and the highlight report from the Quality Committee. As you'll see, we received a number of clinical service reports around SEND, which Ed has referred to. There's a huge amount of work from both Richard's piece of work on the joint commissioning and the pace setting challenge that he's setting our Essex colleagues, which is being received really well, and also the governance review that Leanne in my team is leading with the 4 quadrants in Essex to make sure that we are all reviewing and reporting the same information, and we're pulling together one SEND health dashboard so that we can understand any inconsistency in access to services for children with SEND. So we received that update. We received a report on CHC, patient experience. Obviously, we had word on the street, which is always incredibly helpful, and a paper on E-East and the work that's ongoing with E-East. So a number of discussion points were raised and risks. So the first one that I was just going to update you on is around the staffing for our community beds, particularly in Clacton Community Hospital under ACE's provision. So there Harwich Hospital staffing is okay, but Clacton Community Hospital, they still have some significant vacancies. I think around 70% of their Band 5 registered nurse vacancies at Clacton Inpatient Community Hospital on their contracted beds, and haven't been able to recruit to their winter beds either. So Pam and I are obviously having conversations with the directors within ACE, and my team are working with ACE on their risk assessment and the mitigations that they're putting in place to ensure that patients are safe. The second area that we discussed was East and their CQC inspection and their structured programme of support with the National Improvement Team. They have a 10-point plan, and they have some really great support from the national team with Sue Holden, who's a National Improvement Director leading that, which is being incredibly helpful to East and is really challenging them to look at the way they manage the organisation in a different way. They have a new interim director of nursing, Juliet Beale, who is working with them for 6 months, while Tom Davis, the director of quality, the medical director, is acting as the interim CEO. So that feels that it's moving forward, and we now have an oversight and assurance group arrangement as the Easter in special measures, whereby we attend with the other ICS dons across the east of England to make sure that any issues at locality level are fed into that oversight group arrangement. We discussed the fact that ESNEFT have now transferred to the new patient safety incident response framework, and EPUT are also about to go live. Their boards have approved their framework, which is really exciting. We met with Joe Allen and myself met with the Essex Coroner's Office just to talk through the fact that we're no longer working to the serious incident framework, and the patient safety reports that they see will look slightly different. So we are meeting with them again in a few months just to get feedback, because obviously we are an early adopter of the new framework, and it's important that we get feedback from all stakeholders. There was a report on the Signet Group, and Signet Yew Trees has now closed. That's overseen by the Transforming Care Partnership Board in Essex, and as host commissioners, we've been working closely with Phil Brown and Essex County Council and CQC to ensure that patients have been safely transferred, residents have been safely transferred, and also through that process of Yew Trees being closed. And we also reviewed the clinical prioritisation and risk assessment process to reduce clinical harm occurring to patients on a waiting list. As we've discussed, ESNEFT are doing incredibly well around their waiting times, but it's still important that we make sure that patients don't receive any harm while they're on the waiting list. So I think that's all I was going to update, but happy to take any questions, Chair.
Okay, thank you, Lisa. Pam, did you want to comment? Pam D. I see you, Max, but I just wanted to...
No, I don't feel I can, because unfortunately I wasn't at the last meeting, but Mark chaired on my behalf. He may wish to say something, but my apologies for that. Thank you.
Thanks. Mark, did you have anything to add?
Nothing to add, Chair. I think Lisa covered it all. Thank you.
Perfect. Thank you. So, Max, you were waving your hand at me.
Yeah, so thank you. Can I just query? I always look at this. I know it's a bit of an old chestnut, but I always look at the one of the first things I try and find is the mortality statistics for the two Colchester, and it stubbornly is above, the Ipswich side of ESNEFT, and it's been stubbornly there at that level for many years. And I just wonder why, to be honest. Is there some sort of statistical quirk that's going on around our aging population, or why is it? And I know it's not. I know it's always kind of reported as being within range or something like that. Which is sort of slightly reassuring, but it's always higher than the Ipswich side, and I'd just like to understand a bit more about that, please.
Yeah, I have to be honest, I'm not sure what. I could make some assumptions, but they wouldn't be based on evidence, so I'm not going to do that. I'm not entirely sure why Colchester site is high. As you say, it is within the as expected portfolio, but we also we had the ICS quality surveillance group today, and we looked at where we benchmarked against the East of England, and actually SNF does quite well against the East of England benchmarks for HSMR. But we could make that a focus of the next quality committee, Max, and feed back to you at the next board, if that's okay.
And there's a kind of, I don't know, I think there's a bit of mention in there about higher rates of incident reporting. I don't know whether there's any link, or whether
No, I don't. I honestly don't know. I know they had some data issues which led to some reporting blips, but I think I probably need to get the reality from Angela Tillett before I respond.
Thank you.
Okay, thank you for the question, Max. Has anybody else got their hand up that I can't see? Silence is no. In which case, thank you, Lisa, for the report. That's noted. So you next, Pam? Green. You're on mute, Pam. It's your area prescribing committee.
Yeah, just bear with me a second. I'm just getting to the page. So you'll be aware from previous meetings that the TDC Transformation Delivery Committee, as was, now covered most of its work by the Alliance, but we have established an area prescribing committee to do the medicines work, because it doesn't fit so well within the Alliance remit. So this is the report from the committee, the last meetings of the committee since we last met. And you can see within that the approvals of medicines, the areas of concern still, which links into the practice recovery visits that we are looking to get started again with the medicines management team and the elected members, particularly around antibiotic stewardship, etc., etc. So you can see the work of the committee, and also if I go to the memorandum of comment on as the controlled drugs lead for the CCGs, there's a memorandum of understanding that we need to sign as a CCG around the management of controlled drugs. So I'll take the paper as read, and I'm happy to take any questions.
Thanks, Pam. You might have to help me see if anybody's got their hand up.
Max has got his hand up, but I don't know whether that's an old hand. No, okay. Apparently that's an old hand. Right. I'm glad he's not asking me a difficult question.
I think you just called Max an old hand, which I think is a bit inappropriate. Old hand. Okay, so if we assume nobody's got their hand up, we're asked to note the report and the memorandum of understanding. Sorry, Pam, did you say who signs that on our behalf?
So Lisa, you're our controlled drugs lead, aren't you? So providing Lisa's happy with it and I'm happy with it as area prescribing committee delegated member from the board, then with the board's blessing we'll sign that. Okay,
you happy, Lisa?
Yes, I'm very happy, thank you.
It's a regional document, so we haven't tinkered.
Okay, thank you both. And so let's move us on then. So Jane, are you able to take the audit committee report just in Jerry's absence?
Yes, no problem. So the report is in two parts. First of all, it's a report on the last meeting that we had, and it also picks up the 1920 report of the audit committee's business. I will assume that people have read it. It kind of sets out everything that we did during the year, all the reports we received from the various auditors, etc. But happy to take any questions.
You're going to have to help me out again to see if anybody's got their hand up.
No hands.
No?
Can't see any.
Okay. All right. In which case, we'll ask to note the report, aren't we? And so we'll note that, and let's move on to GPCC.
Again, take the paper as read. Covers the activity that we've undertaken since last the board met. Significant pieces of work that have been underway are alignment of care homes to PCNs. And when you have 175 care homes in your patch and 10 PCNs, it's a significant amount of work. And I'd like to pay credit to the team that have supported that during the last couple of months in readiness for the care home DES that was launched nationally. A real challenge, as I say, just in quantity, but we've worked with a protocol to try and align fairly the income and support that practices will need to give to care homes. But it's a hugely contentious area, but I think we've got to a 95% satisfactory position. I don't think we'll get 100%. We've got 100% alignment, but not satisfaction from practices, but we're working through that. Also, so we continue to report progress around the stability of practices and the performance of practices in that setting alongside the LMC. So I'm happy to take any questions. We have developed some new performance scorecards with more data in them. And again, working with the LMC around how we maintain performance and support to our GP practices.
Thanks, Pam. Any questions from maybe Prashant, Frida or Firas? I haven't heard from you guys. Make sure you're still there. Has anybody else got their hand up?
No hands, Hassan, no hands.
Okay.
That's fine.
Prashant, anything to add? Okay, I thought I heard some voices there, but
no questions from me either.
No, not from me.
Okay, perfect. Thanks, guys. Okay, in which case we're asked to assure ourselves that GPCC is functioning, so we'll take no questions as our reassurance. So let's move on to the COVID Resource Approval Committee. Jane.
Yes, thank you, Chair. So just as a reminder, the COVID Resource Approval Committee is a committee that works across the 3 CCGs that we put in place early in the year to enable quick decision making, particularly associated with the COVID response. So what the report does, as we've done at previous meetings, is set out the decisions that have been made by that committee since the last report. So we reported that when we met last time. This also goes to the Finance and Performance Committee, who have got obviously a little bit more time to scrutinise in detail and ask questions. But effectively, it's really just for that assurance, so you can see the decisions that have been made by that committee. There is an additional recommendation in this report, which is to ask to extend the committee until the end of March. Previously, I've been coming every couple of months and asking for a short extension. Just to assure the governing body we are pushing as many decisions as we can back through the alliance governance. This really is about anything that we need to do and make quick decisions either through around the second wave or particularly around mass vaccination. So it's really just as a backstop to help us and stop coming back every time just asking for a short extension.
Thanks, Jane. So questions? Martin, Martin, has any concerns? Comments?
No, none at all, Hassan. Every F&P meeting we get an update from Jane, and we do discuss it in some depth. We look through the figures, and we actually discuss where the money's been spent. We're obviously very aware that the end of the day it's public money and it has to be spent well, and we do ask all the right questions and get assurance that where expenditure has been made, it's been made appropriately.
Okay, thank you, Martin, and thank you, Jane. I'm afraid you'll have to once again help me if somebody's got their hand up, because I can't see anyone other than Max who's got his hand up on mine, which I'm assuming is old still.
Can't see any new hands.
Fine. Okay. In which case, thank you. So we can take that as noting the report and approval to extend the COVID Resource Approval Committee till March 21. And so, Amanda, you want us to have another go, seeing as right at the end. Do you want to see if you can?
So mic is off.
Oh, there you go.
Yay.
We can hear and see you.
Thank you very much indeed. So here we have our updated risk report that's obviously reflected of November. And what I wanted to add to the report today are two things. One, we have just been audited by RSM on our risk management processes, and early indications are looking pretty favourable. So there will be a report come back to Audit Committee ASAP. The second update I wanted to share with board is that we are going live with our risk management on Datex. So I think that will help strengthen our approach to risk management across Suffolk and North East Essex. And my third point was reflecting the earlier risk management strategy that we approved. And in line with that, what I would want to do next time you receive the strategic risk report is to also receive a directorate summary report, which basically highlights the top 2 or 3 risks per directorate that are bubbling away that may find itself on our risk register going forward. So that's another element, if you like, of strengthening our approach to risk management. I guess my final point would be that we now have a good joint risk forum across Suffolk and North East, and that's work in progress. We've still got a bit more refinement, but I think given where we were 12 months ago, we are doing good with all our approaches to risk management. So I'll pause there, but very happy to take any questions. Thank you, Chair.
Thanks, Amanda. Nice to hear from you. Max? You're on mute, Max.
Yeah, so thanks for the report. Very comprehensive. Just in terms of, because I know from the kind of the risk revised risk policy or whatever we had, that we're trying to sort of set a sort of timeline for risks changing from what red to amber to green or whatever. So can I get a feel from that report, you think, now what our timelines are for things to be improving?
Yeah, sure.
But is there what sort of timelines can we expect for improvement?
Well, in terms of that particular question, thank you for that, Max. And I think it's regarding the target risk that we now are assigning to each of our risks. That is a conversation that we're actually having this Friday at the Risk Forum, where we want to, as a group, really get underneath, the target risks that are assigned to each and actually make sure they are meaningful and that we're not just continuing to manage risks without actually having an end in sight, because the whole idea of our approach to risk management is to mitigate and do everything we can to reduce or eliminate the risk going forward. So it's very much something that we are working through as a risk forum. And as I said, we're meeting on Friday, so I'm hoping that we can better answer that going forward, Max. And I'm very happy that we can capture that in the action log, and then following Friday's meeting, I can update accordingly.
And just sort of following on slightly from that, if I can, Chairman.
Yeah, sure.
So you kind of also the risk policy, whatever it was called, kind of indicate what actually there are areas where you might take a higher risk or be kind of like, whether it's more about innovation or something like that. It's not really about necessarily patient safety. Obviously, you'd have a very low risk policy, if you like, keeping things at low risk. Is that maybe worth adding some of these things that we might think actually, or we just don't think that should be in the risk register, those things that we actually would have a high risk attitude towards? You see what I mean? Are we only looking at things in the risk register that we're worried about the risk, even if, because there are things that we do that could be high risk, but actually that's not necessarily around patient safety. It just means it might not be successful.
Absolutely.
Might be a financial thing or something like that.
Sure.
Yeah.
Yeah. Okay, so all of our risks would, in terms of prop part risk management, have a target risk. There will be some risks that naturally have a higher risk rating and higher risk appetite. But I think, you know, what we need to be doing through our risk management framework and indeed governing body is to be seeking the necessary assurances that actually we're doing everything we possibly can to manage and mitigate and, where possible, control the risk. So there isn't a one answer for each individual risk. It would depend on the absolute risk. I'm probably not answering it that well, am I, Max? Martin?
Muted, so I'll be muted.
Yeah, I just wanted to say that, you know, the safest way to run a railway is to keep all the engines in the shed, and this alludes to really what Max was just saying. Sometimes you have to have an appetite for risk if you want to actually achieve anything. And I work in a business which is incredibly risky, and we have a very high appetite for risk. Otherwise, you get nothing done. So how do you manage risk appetite, looking at all the various, you know, the RAG system?
So the risk owner would, in managing their risk, consider what the appetite is for their particular risk. And then we collectively, as a risk forum, then work that through collectively.
Okay, thanks, Amanda. I think in essence what we're saying is that actually on the risk log it should be items that we're concerned about, that we need to observe. And so if we've got a calculated risk that as an organisation or as a committee we're satisfied is an acceptable risk, then that shouldn't be on the risk log. So
absolutely.
Does that pretty much sum it up? Okay. Has anyone else got their hand up?
No,
I can't see any hands, Chair.
Right. Perfect. In which case, thank you.
Thank you,
Amanda. We note your report. And then we've got Jane.
Yes, thank
appointing
you.
Some auditors.
We are. So people will remember that at our last committee, we talked about the process for appointing external auditors. We put in place an auditor panel, which is a formal requirement on behalf of the governing body. Since then, we have received the bids, we have undertaken a shortlisting exercise, and we've interviewed the 3 candidates. And can I say huge thank you to Jerry, who was involved in that all along, which was quite a laborious process, but it was very grateful for his input on it. The recommendations are in the report. The auditor panel is recommending that we appoint BDO as our external auditor. That will be a joint external auditor across the 3 CCGs, starting from next year's accounts.
Okay, any questions? And are we happy with the duration of that contract?
So it's a fairly flexible contract. So okay. We built into the tender around the opportunity to bring that as if it's one organisation or whether it remains as 3 organisations. So that's all built in, and there is sufficient notice periods in there that it'll be flexible enough.
Okay, I'm sure you would have, but I thought I'd ask anyway. So I don't see any hands up, but I haven't for the whole meeting, so I'm just going to plough on ahead. So we're asked to note and I assume approve the. Well, we'll note the report. Thank you, Jane. And then our last report, last but not least, I don't know if Councillor Brown joined us. She was coming in and out on my computer. Is Councillor Brown around? Councillor Brown, you're on my list, but you're on mute. I don't know whether you wanted to introduce your report.
Unmute, sorry. Oh yes, it is unmuted now. Sorry about that. Okay. Yes, Hassan, thank you very much. I did a report on the last Health and Wellbeing Board. I thought it was a really interesting board. I don't know what you thought, but I thought the item on suicide was something really worth noting. You were there, perhaps you can pick up the points that you think would be relevant to the CCG.
Well, I think, to be fair, we've talked about the item throughout the board today, haven't we, in terms of the higher incidence across our patch. And I think what's clear is not least suicides, but the importance of mental health across our patch and, well, really the rest of the world, if I'm being honest, is a growing concern. So it was a welcome announcement for Matt Hancock to commit to further investment. I guess the action for us is as a board, as a system, how we approach this and how we make it so that we've got something in place to help our residents more so. And that's linking everything that we've talked about so far with Councillor Corey's contribution around the offer for the council to work with us. It's just really how we come together as a system to address this. You may remember, I think, I'm not so close to it, but I believe it was always one of our ICS higher ambitions, wasn't it, in terms of a zero suicide rate, and I'm hoping it still is. So it's a theme that runs across, and I would welcome some contribution from the right people to try and actually address it. I think it's clear that we need to.
Yeah, I thought the coroner's office was very interesting on that subject, and it's something that we don't want to sweep away. We should look a bit deeper, I think.
Indeed. We've already sort of committed to bringing it back as a theme for one of our boards. I think that probably needs a bit of thought in terms of how to do that meaningfully. And I don't know whether that could be worked up at either the Alliance Committee or the Quality Committee or both. But I think we could do with that, couldn't we?
Yes, I think so.
Okay.
Hassan, I have put my hand up.
Sorry, I didn't see it. Sorry, ma'am.
So there's a lot of interest, obviously, in this within the alliance, and I think we've got the right partners to raise the awareness. If you talk to colleagues in the Mental Health Trust, there's indicators that we should be looking for, and they're even working with hardware stores, taxi companies, all sorts of people around raising the awareness and how to intervene around suicide. So I think, again, whilst it's a health indicator, and we're working with Linda Moncur around our dashboard of quality indicators for the Alliance, and a lot of partners have said we want to see suicide on there, and what the Alliance is doing about it locally. But we have to take that wider determinants of health approach to it. So it is about employment. We know, as Lisa said previously, you see that spike in mental health issues when after an economic downturn. We have to take a very multifactorial approach to this, and I'm happy that as an alliance we bring back to the board the collective work that we're doing through voluntary sector, etc., and with the mental health team, GPs, so that we can give you a rounded report.
Okay.
Yeah, I think absolutely right.
Thank you, Pam. You'll have to help me out to see if anybody else has got their hand up. Sorry, I can't see. No. Okay.
Not that perfect. I can see. No.
It's very useful being able to see Jane shake her head when asked that question. Thanks, Jane. In which case, Councillor Brown, thank you so much for the report. It's very welcome.
Thank you.
And I think that brings us to the end of the agenda, unless there's any other business that I haven't been advised of beforehand. Luckily, I can't see any hands raised anyway, so I'll assume that's no. Thank you, Jane. My barometer. In which case, I'll call the meeting to a close. Thank you all for your attendance. Just a reminder to some of the board members that we're going to have a short part 2 meeting. Can I suggest we have maybe 5 minutes as a comfort break and then just crack on to try and finish